Hi, this is Brian Kim. I'm going to share with you this challenging case. This is a white 3 to 4 plus dense cataract with zonulopathy and needing a capsular retention ring. You will see double chop, cross chop, mechanical fracturing, and the ways I'm able to crush the lens pieces, minimizing zonular stress, using mechanical fracturing to pull the lens pieces up out of the bag, and also being able to reduce CDE and having clearer corneas. I use a corneal mark to help me center and size my rhexis. I make my paracenteses incision and then inject intracameral lidocaine and epinephrine. I inject intracameral air and then trypan blue to paint the anterior capsular surface. You don't want to put vigorous trypan because it might go into the vitreous space. So I like to just drop it on the anterocapsular surface and then paint it like a paint roller. I inject dispersive viscoelastic. I make my triplanar corneal incision. I make a vertical groove and then tunnel and then enter the anterior chamber. I then do my capsular rhexis. I do a puncture style capsular rhexis. I puncture the center and pull down and sweep a little bit to the right to make a C-shaped configuration. And then I grab the flap. I try to follow the contours of the corneal marks that I made. And then I make a well-centered and sized capsular rhexis. I then do my capsular fornix hydrodissection technique. I place the cannula out to the equator, point it down towards the nerve, and get a nice fluid wave. I decompress on the left side and then spin the lens on the right side. I lift my incision with the chopper and then go into the eye with the phaco tip with irrigation off to minimize Descemet's trauma. I then begin my lens disassembly technique. But first observe how much tip I have exposed. I've really pulled the sleeve way up in order to expose that metal tip, and I did this because this is a much denser lens and this makes the double chop much more easy. That can chop a much denser lens exposing that tip like that. I remove the surface epinuclear material and then perform the double chop. I place the chopper out to the equator. I turn the phaco tip deep into subincisional space vertically, do the double chop maneuver to get around the entire thickness and density of this lens. I place the chopper out to the contralateral equator and then crush the right heminucleus in half, and this is the cross chop maneuver. I'm able to get around the equator, crush this first quadrant, and then pull the lens piece up with the chopper, and I'm gently, again, using mechanical fracturing forces to crush the lens material into smaller bite-sized pieces. I go back with the chopper out into the equator and try to grab the lens pieces once again. I'm using vacuum to grab the lens pieces, and then using pulses of ultrasonic energy, I'm able to emulsify the lens pieces. I'm going to spin the lens now and go after the second heminucleus. I place the chopper out to the equator and place the phaco tip deep. I bring both instruments together to crush the lens. I want to make sure the phaco tip is deep so that I can get around the thickest part and the densest part of the lens. And then I go ahead and use mechanical fracturing forces to get around the lens pieces, making sure I get around the lens piece completely. And there might be some leathery attachments because this is a dense lens. And when you encounter these leathery attachments, you just want to continue to crack and spread both instruments apart in order to propagate the cracks. I'm using both the chopper and the phaco tip to manipulate the lens pieces, and then using vacuum to help hold the lens pieces, and then I crush the lens pieces using mechanical fracturing forces. You can see here that this capsular bag is flopping on the periphery. You can see from the surgeon's view at the 12 o'clock position and 3 o'clock position, you can see there's quite a bit of billowing of the capsular bag. And so this is a sign that this patient does have some weak zonules. I'm using successive forces of mechanical fracturing to crush the lens pieces. I take the chopper out and then fill the eye with more viscoelastic. I turn the lens piece, this is the last quadrant in front of me. I place the chopper out at the equator and then very carefully I place that phaco tip deep, making sure that I'm able to bisect that quadrant completely. And then I'm using mechanical fracturing forces to make sure each of these dense pieces are broken up into smaller size pieces, and then I emulsify those smaller lens pieces. You can say this is a pretty dense lens, but the CDE is not nearly as high as it would be otherwise using traditional techniques. Rather than impaling the lens pieces with high ultrasonic energy and vacuum, I like to mechanically manipulate the lens pieces with the chopper and the phaco tip so the lens material is positioned between both of my instruments, and then I crush the lens piece completely, and then using episodes of vacuum, I'm able to grab the lens pieces and then crush the lens pieces with a chopper and phaco tip. Once the pieces are small enough, I go ahead and use the ultrasonic energy to emulsify the lens pieces. This is a few last fragments left. I want to be very careful about making sure that the posterior capsule is completely protected because there is no epinuclear material left in this very dense lens, and you can see the bag is quite floppy. I'm being very, very careful, making sure that chopper is deep in the bag so that I don't accidentally grab it. I'm switching to the BSS cannula and irrigating into the eye. I pull the phaco tip out and then the INA tip in. I'm doing my fluid exchange. As I'm doing my INA, I notice very quickly that there is significant zonular laxity. Even though the cortex is fairly clean, you can see that there's no safe way that I can peel off all of this cortex without stripping more zonules. So I decided to put a CTR in. I load it into the injector. As I'm injecting it, I use a Sinskey hook to grab the leading eyelet. As the CTR is going into the eye, I'm making sure that the Sinskey is minimizing any trauma on the capsular bag. I'm trying to perform any cortical cleanup since I had to put the CTR in while there was cortex in the eye. But you can see that the bag is very unstable. So I'm doing the best I can to remove any remaining cortical material, but I don't want to be too aggressive because if I am, I might cause more zonular damage. By switching to polish, I can really be very gentle and minimize any stress on the zonules. I'm using a BSS cannula to flush the capsular bag, including the subincisional fornix. I fill the eye with cohesive viscoelastic and place my 3-piece intraocular lens into the capsular bag. I'm using a Maltzman to help me dial the trailing haptic into the bag. And then I go to my INA, lift the edge up of the optic and tilt it in such a way that I can access that space between the posterior capsule and the lens. And I'm able to remove any viscoelastic material between the bag and the lens. And then I'm going to remove the viscoelastic in the anterior chamber, and then I hydrate my incisions. So this is a case, again, a 3 to 4 plus dense lens with fibrous lens material, making it difficult to crack and separate the lens materials. But by utilizing mechanical fracturing techniques, double chop, cross chop, using mechanical forces to crush and separate the lens material between the chopper and the phaco tip, doing all of these maneuvers within the central safe zone, pulling lens pieces up out of the bag so that I don't have to use any torsional stress on the zonules, placing a CTR with an atraumatic technique with the Sinskey hook. I'm able to put the lens into the capsular bag, minimize zonular stress, minimize ultrasonic energy, and this patient had an excellent outcome. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.